Hello, this is Jessica Shields, and this is Discussion Board 6. I am replying to Dena's post, and I want to start by saying how thorough your post was. You definitely gave a lot of signs and symptoms of patients that are possibly abusing opioids. You were very thorough with your interventions and everything, so I definitely enjoyed watching your video, and I definitely agree with a lot of your signs and symptoms, and some of them ones that I usually look for are the poor nutritional status, the needle marks, the inflamed nasal congestion, because a lot of people, once they, once they've been taking the pill by mouth for a long time, they start getting immune, so they try other routes like snorting and injecting and different things like that. So I mean, it could still be opioids, and they could still have needle marks and nasal congestion. Constipation is the big one, chronic constipation, because that is from Percocets or from opioids usually, and other ones that I wasn't really aware of. Well, I mean, it could definitely be possible, but it's just not something that, whenever I see it, I'm like, oh, opioid abuser, like the adventitious lung sounds and the arrhythmias, and the cellulitis. Those three that you mentioned, I would definitely probably do some more research on, just to find out why they cause those things, because whenever I hear adventitious lung sounds like rock eye or rails or things, I think other things like pneumonia or fluid overload, other stuff like that, which I mean, it definitely could be both. And some of the behaviors I definitely agreed with, the slurred speech, the staggered gait, the drowsiness, and the mood swings. Those are the big ones that stuck out with me, that I definitely agree. Especially the mood swings. I mean, they'll have euphoria, and then the next minute they're depressed and they're crying, or they're angry and trying to cuss you out or whatever, and I definitely like the intervention about recognizing addiction by really doing a thorough history and finding out how many doctors this patient is seeing, and how many pharmacies they go to, because they might actually tell you and think that you're not gonna realize that they're doctor shopping. They might just tell you off the spur of the moment. So if they're a patient at 5 different pharmacies and they have 5 different doctors, I mean, that might be a red flag if they're all medical doctors, or if they're all in the same class of doctors, that's definitely a flag. So I definitely agreed with that one, and asking about just doing a thorough med recognition sheet, and just or reconciliation is what we call it, just making sure we write down every med that they're taking, and whenever they leave the hospital, making sure that we go over that, and just to make sure that we're not doubling up on anything. If they're taking something beforehand, we don't want to prescribe them something else in the same class or for the same thing. We want to make sure we're really doing thorough med reconciliation profile on each and every patient, and really finding out their family history and personal history, because if they have a history of depression or anxiety or substance abuse in the past, they're going to be more likely to abuse again or start abusing because of the family history or personal history, and a family or personal history of depression or any psychological issues could definitely lead to substance abuse too. And I really liked when you mentioned, because it's very true, and I hope more nurses are doing it than I have noticed, but really assessing the patient's pain goal, because we're not going to be able to get everyone to a 0 to no pain. So just assessing them and finding out what is comfortable for them, their pain goal. Whenever we are doing our charting and we are doing a pain assessment, it has a little box in there saying what is the patient's pain goal. And I'm sure everywhere don't have that box, but it's just something good to know. That you should be asking, because if they're comfortable out of 5, and you go in there and ask them what their pain rating is, and it's a 6, to someone else that might be severe pain, but to them it's really just mild pain. So you could give Tylenol instead of giving morphine, or whatever the circumstance may be. So that is very important. And once you address the pain goal, write it on the board, or making sure you write it somewhere so other nurses and other people in the medical team know what their pain goal is. And definitely telling the nurse and shift report, pass it along, just so the message gets passed along. It's very important. And I do agree with you about in the OR where y'all are just kind of treating the symptoms. Y'all are not really, the blood pressure high, you treat it, blood pressure's low, you treat it. I definitely agree with that. And you'd be surprised that's kind of what most of the floors do. They just treat symptoms as they come. And I've noticed a lot of times they don't look at the big picture, of why it's doing this or why it's doing that. They just try to treat, and then before you know it, they're addicted to pain meds. But great post, and this is the last one. Thank you.